welcome to another edition of Grace Under Pressure, where my guest today is Dr. Philip Brown. I'll tell you all about Dr. Phil in just a moment. Grace Under Pressure is that show that deals with what's too often dismissed as the soft stuff, the caring, the commitment we exert toward others. And when you do it as a leader, as you will definitely discover that Doc Brown is, you do it with a common cause of bringing people together. Dr. Philip Brown, welcome to Grace Under Pressure.
Thanks for having me, John. I'm really excited about the chance to have a nice conversation today, and hope it'll be helpful to some folks out there listening.
I definitely know it will. I want to tell folks a little bit about you. Dr. Philip Brown is a physician, retired vascular surgeon. That's really hardcore work, let me tell you, vascular surgery. Anyway, now he's involved in executive leadership and executive leadership development, and he is an executive himself. You are done a lot of things medically, but you have a brand new book out called How to Speak Patient, and that has resonated with me, and I wanted to share its lessons with us. So let's jump in.
I'm really excited about the book because the book is really designed to help people think back to fundamentals and put in their own ideas based on their experiences. Obviously, the book is written based on my experiences, but in the AHA format, it really is designed as an actionable journal. And so the reader is able to get through the entire book in about an hour, but then use a tremendous amount of time going back through the reflection type exercises in the AHA points to put in their experiences. And in that way, potentially reconnect with their purpose, with why they got into medicine or healthcare in the first place. And really, I look at it as a great way to build teams, to build a community around really the fundamentals of helping take care of people, taking care of your fellow man.
Well, that's good. And excuse me, the book is called Do You Speak Patient? And so
Right.
it gets to the point. And let's just get back up. I love what you just said about why I went into medicine and why I went into healthcare, because that seems so obvious, but what happens when one is in practice for a while? Phil, tell us about that. What happens to the working conditions?
All the stuff starts to get in our way. A lot of it is ourselves. A lot of it is the sort of the baggage that we build up over time and helping take care of people. It's a fairly emotional, intensive business when you're helping take care of fellow human beings. You see a lot of bad stuff. You see a lot of great stuff. And so it becomes this, mountaintop and bottom of the well experience if we're not careful about it. And we can get stuck at any place along that continuum. I've seen it a lot of times. I think we tend to talk about the burnout piece as being at the bottom, almost akin to depression or something like that. I'm not sure that's exactly right, quite frankly, because the truth of it is that most of the whole practice experience, just like most of life, is lived somewhere in the middle, right? It's not the depths of despair or the heights of ecstasy. It's somewhere in the middle. And so being connected enough with our purpose that we can be comfortable living in that middle part. It's kind of like walking in the Tao, right? I mean, we have to be somewhere in the middle and be okay with that. And it's only when we're not that we start running into trouble with burnout and those other things.
I like that analogy, and I know you, if I remember correctly, you are the son of a basketball coach. Am I correct? So
Absolutely, yes, sir.
So your metaphor about being somewhere in the middle, I've heard many coaches talk about, I don't want my team to get too high. I don't want my team to get too low. I want them right in the middle. That sounds really good for athletes and all that. But I'm thinking, and it makes sense for what you say in physicians, but in the light of burnout, if I'm always in the middle? Do I become deadened to my purpose, or deadened to what's going on around me? What's your take on that, Phil? So,
Yeah, I think that's the trick. I mean, the real trick is that you have to be comfortable at all the places, because organically built into the experiences are some lows and some extreme highs. And the idea, I think, is to be with all of those sets of experiences when they're happening and be okay with them when they're happening, and then be able to release them, right? It's not, if let's say that you're taking care of somebody who, maybe as a family friend, as somebody who practiced in my hometown for, a long time, I was taking care of my peers' parents a lot of times as a vascular surgeon, and sometimes some of those situations that they found themselves in with extreme vascular disease were really situations of despair for the patient. And as somebody who's connected to them as as a physician, as a family friend in many cases, were I to become trapped in that despair, it would be very difficult. But at the same time, I need to have empathy. And so when I'm with that patient, it's being in that moment and being very in tune to what they have to be experiencing and feeling.
it comes, and I like the way you express that. It comes down to a matter of trust, which is so essential in any relationship, of course, but patient to physician or patient to healthcare worker, you got to have trust. But so often, I think things get disrupted. So, what's getting in the way of that,
Wow,
Phil?
that's such a powerful question, John. I appreciate you asking that one because right now we live in a low trust era, not just medicine. I mean, like it is low trust in a lot of places we look. Now, fortunately, in medicine, if you look at the most trusted professions in America, number one and two for decades running have been number one nurses and number two physicians. And so there's a little bit of an advantage in that environment, but we just experienced this global pandemic, which created horrific mistrust in healthcare providers. And that's really unfortunate because, the truth of it was in that pandemic, things changed several different times, but that's because we learned more, we understood better how to do. And so, people had a hard time adapting to that. And then we got into the political cycle and quite frankly, that was exploited for political gain. And that created an even more profound atmosphere of distrust. And that's really what we're still recovering from now. Add to that the flip side of it, we often think about, well, gosh, the patients aren't trusting the healthcare providers anymore. Well, there's another side to that the healthcare providers don't know when they can trust the patients anymore. We look at common accounts of violence in hospitals, violence in doctors' offices, profound, uh, what's considered not following a treatment plan. We call it non-compliance. There's all this doctor shopping. There's the whole substance abuse component, which had to do with a lot of, in many cases, patients who were provider shopping to get these prescriptions.
Sure.
And so we've just got this whole milieu of challenges to trust.
That's I'm glad you gave the macro and the micro picture. And I never ever thought, I'm the son of a physician. Many leaders know this. I never ever thought that healthcare workers would ever be at risk physically in our country. But sadly, uh, it has intervened. So, but one on one then. So, when doctors come to you, physicians or healthcare people, say, well, how can I restore trust? What's your take on that, Phil?
Well, it's through relationship, and it's really easy to say, but harder to do, because the first step in really helping restore that trust is to get yourself out of the equation when you're having the patient provider conversations, right? Convert it into
Explain that. Yeah.
yeah,
Okay.
right. Like it's kind of
That
like
sounds almost like a mind trick here. So you're
well,
providing the
it is
patient,
right. And
and
so
you're
it's kind
saying,
of
take yourself out of the equation.
yeah, it's kind of like the saying that silence is not the absence of noise; it's the absence of self, right? And so to really establish trust in a provider patient type relationship, the first thing that has to happen is there has to be confidence on a part of the patient that the provider listening to them, whether that be a physician, whether it be a nurse, whether it be any health related profession, really, that they've heard them. If the patient begins to feel heard, you have really taken a major step toward developing trust. And so the first thing you got to do is turn off that judgment piece as a doctor, for instance. I'll just speak as a doctor. And you know, the tricky part about that, and I said it was simple to say but hard to do. And I really mean that, because the thing is that all the pressures in the patient care system now are a race to the right answer. And so if you're the physician, you're really trying to hurry up and get to the answer, hurry up and get to the answer, hurry up and get to the answer. So sometimes there's a tendency to cut people off when they're talking. Sometimes there's a tendency to jump to conclusions or make assumptions based on this whole body of clinical knowledge that you carry in the back of your mind. And if you jump to that solution making phase too early, it really erodes trust, because the patients need to first know that they're being heard. And it might not even be hearing them about the clinical condition that they're talking about. It might be about hearing them in some other component of their life that they believe is important to the ultimate decision of care that will come later. And so, when you think about it, it's kind of just like a conversation with a member of your family or something that you know, there kind of has to be a rapport first before you begin to hear everything. And then before you get this, like our friend, Molly Chang would say, shared reality. So ultimately it all comes down, you'll have perfect trust when you're able to develop a totally shared reality. And the challenge for the physician is to give that enough time to develop. And there's some specific ways that can be done, but most of them at the beginning involve, let me take my opinions out of this long enough to just get all the information I need. And that's really hard to do.
You know what that sounds like, Phil? It sounds a little bit like my world of coaching. Don't jump to conclusions and
Oh,
listen and
exactly.
being heard. And I think we all do. And I think you said, so if someone would come to you and when you were practicing for a vascular issue, the challenge is for you to listen to whatever they want to tell you about another aspect of their life, their situation, in addition to the physiological condition. Is that what you're saying? So,
It is exactly, and that's kind of a source of the acronym Tell Me that's in the Do You Speak Patient book, because that was my shorthand way of initiating a conversation with a patient, whether it's a new patient or a patient that I've been seeing for some period of time. I would always just open it up by saying, "Tell me what's going on today," and that really was an open-ended way to open the door to what was foremost on the patient's mind at the time. And I had people who came in and talked to me everything from exactly what was going on with their health to how their deer hunting season had been that year to what was going on with their grandkids and anything. It really doesn't take a long period of time to hear that. But what you're really doing when it goes like that is you're kind of creating a space, and then you can. So you've created this invitation in the way of, this open ended. Well, tell me what's going on. You continue to reiterate that, right? Well,
Right.
tell me a little bit more about, you tell me that your legs hurting when you walk a certain distance. Tell me a little bit more about that, and you kind of can help narrow down the conversation using the same tool. And that's kind of where that acronym came from.
I mean, it's so simple, but we don't use it. But now let me do the healthcare provider flip side is Dr. Brown. You need to see 10 patients or 12 patients or 15 patients a day, whatever it is, and so get to the point quick. As that is factoring in too, is it not? So
Well, I think it factors in a lot and probably more than it should, honestly. It's one of those pressures. That's why I was saying earlier, it's hard to accomplish. But once you know how to do things that way, for me, it really saved time. But it put a premium on my ability to listen. And honestly, I mean, in full transparency, some days I was better at listening than others, right? But it takes you down a path, and it's kind of the same way that I like to coach teams. When I'm working with teams, I really like to, or I tend to gear it toward things they're actually working on, not an exercise, right? Let's put this in the context that you're actually working. We'll mock it up right now, but let's let it be a real problem. Same thing with the patient, right? You're asking them to go to their context right out of the beginning, which at first can make it a little difficult for you. If you've read I go in the door, I pick up the chart before I go in the door. It says, the patient has claudication, which is pain when they walk, usually caused by lack of blood flow to a leg. If I go in there with that mindset right out of the gate, it's going to be harder for me to let them take the lead. But if I can suspend that judgment, take me out of it, and just have them say, tell me what's going on, they know why they're there to see me, right? It's part of their story to tell it the way they want to, not the way I want to hear it. And if my hearing is as efficient as their telling, we'll get there faster than if I try to lead.
I like that. It's almost counterintuitive, as cut to the chase, doctor. But on the other hand, as you're saying, it can be more time effective. Better for the patient, better for the physician, and also more time efficient to let them tell their own story. And so I think an interesting part of that, because you mentioned working with teams, because you are do a lot of executive lead team development. And this book is a tool for you, and it's a quote interactive book in the sense it's a journal as well. So tell us about that aspect.
That's my favorite aspect of it, actually, even now, because again, I've read it 1,000 times. I dreamed it up, and I'll go back and use those prompts to do my own journaling. In my own hard copy of the book. Right. In fact, I made some notes just yesterday going through I'm kind of working on another book now around how to have a safe hospital stay. And I use the Do You Speak Patient as a journaling prompt to help me think through scenarios and things like that. And it's helpful to keep it in the context. I'll give you an example. I remember fairly recently in one of the facilities I was working with, we knew that there was a problem with the nurses being able to complete their physical assessment of the patients because there were all these demands within the electronic medical record, and we were listening to the nurses, and the nurses were saying, Well, I mean, we just don't have time to be able to go through this whole assessment and then to also the fill out everything that's required in the electronic record. And it hit us like a ton of lead. And we're like, there's a missing connection. Every answer that you have to fill in on that electronic medical record is given by the physical assessment. They're not two different things. It's intended to be a single flow. And so as soon as we were able to make that connection for the team and say, hey, look how parallel, look how these fit, look what this will give you done this way. I mean, it revolutionized their workflow, gave them all kinds of time back, and made it possible for them to spend more direct patient care time, which for many people at the clinical interface, a primary motivation has always been that direct patient care. It's incredibly fulfilling. And so
Right.
when we were able to make that connection, it really worked better. And that was really through the types of prompts that you have in the Do You Speak Patient book.
So you're telling me that when a young person enters nursing or goes into medicine, they're not aspiring to fill out forms. They actually want to take care of patients.
Absolutely. Absolutely. And when we get farther down the realm of AI and all of this, I think a lot of these problems that we're facing now should actually practically go away. But we're not there yet, and so there's still bridges that we have to build for folks to understand how it all kind of fits together. But yeah, that's always an example that I like to share because it really helps underpin that again, fundamentals are really important no matter what sport, game, or business you're engaged in.
Spoken like a true son of a coach, right there.
That's right. Son of a
Uh,
something. Yeah.
Dad will be proud. Uh, here's something else. In the book, you talk about the concept of constraints, and then you say limiting them. So explain that concept to me, Phil. So,
Yeah, I think that, constraints are in the context I'm using it is generally are systemic factors that make it harder to achieve a care plan, right? And I differentiate between constraints and barriers. A barrier is something that really prevents a given intervention or given plan from happening. A constraint is something that makes it more difficult. And we know for sure that anytime you uh, put little blocks in somebody's flow of whatever's going to happen, it makes it more difficult. It's the whole concept, it's the inverse of the concept of nudge, right? Where you just have something that just nudges behavior in a certain direction, makes it easier. And so that behavior repeats. Constraints are really things like that. Maybe it is a system factor in a health system that delays patients getting into the operating room in a timely fashion, or maybe it's something on an outpatient basis that really makes it hard for the patient to consistently take their medication at the same time every day. And so basically, to limit constraints is what I'll call the first step in next level trust. And I call it that because you typically cannot eliminate those constraints. You can't limit those constraints from one side of the equation. It has to be co-created solution. And so that's where the clinician and the patient really look at what's happening together and find a third way, if you will. It's not necessarily a compromise. It's not a split the difference. It's a truly a third way that taking into effect what's happening on either side of the equation, you come together in a way that says, hey, we can move to it this way. Here's what it'll look like. And the fascinating thing about that and why it works so well commonly is that everyone's bought in from the beginning. Clinicians bought in, patients bought in. We have created something that's new and different that has both a piece of you and a piece of me in it. And so obviously we're both going to do our best to try to make that happen. So that's how I look at constraints.
As you're explaining that about the creation process, I'm thinking of our friend Dr. Terry uh, Jackson, who has a book called Co-Creation. So we're doing this together. It's not my solution, not your solution. It's our solution because we're working together. Did I get that correct?
Absolutely, absolutely. In fact, Terry is the first one that I really heard use that phrase a lot. That whole co-creation, his book Co-Creation Leadership is fantastic. Highly recommend that. But that's really where the term came from, and he and I use it frequently in work that we do together. And it's just it's a better way for things to go, especially in this day and time, because it helps. It's really that next level trust. So not only are we're gonna accept each other what we say, we're gonna say, okay, I think this is a safe space. We're gonna say, I think we've heard each other. But when you limit constraints, it's your first step to actually doing something together. That's the next
Now,
step.
there's something in this book that I did not know until we had this little chat prior to going on air. This book is aimed at healthcare providers, physicians, anyone who works with patients. But you said patients can gain from it. So explain that. So
Well, I think that the patients can gain, especially if you're in an active health encounter, using the book at that time is incredibly powerful because it helps you understand a lot of the pitfalls from the patient side. And of course, anytime we're talking about communication difficulties, we know that that's always at least two-sided. There's transmission and receipt both ways. So you could say multi-sided if you wanted to. But I think the patients reading this book and understanding it can help get a better understanding of what the treating clinicians are facing. And it can also help the patients to understand how they can be better communicators. And it also serves as a way to keep a record of conversations because you can record them right within the journal of the different areas you're talking about.
okay. So in that way, as the patients, we are co-creating our health future.
100%. And it will work that way. We would see, if we could really do that on scale across the country, we would see our health rankings, which right now are terrible relative to other developed countries. I'm talking about all of America right now. We would see our health rankings increase immensely if we really got into this concept of co-creation of treatment plans and maintenance plans.
Sounds exciting. Well, we can go on, but we're coming close to the end of our show. And as you know, I ask every guest a story about grace. So, Phil, do you have one you want to share with us, please?
Yeah, I do. Well, I tell you, I think the grace story I'd like to share is, grace of God or whatever power anyone would look up to. But it goes back to my intern year. Matter of fact, it was the first week of my surgical internship. And I was doing one of the very first surgical cases I ever did as a doctor. And the attending physician, who's the supervisor, uh, was in charge of the case, but I was just assisting. And for whatever reason, that attending physician made some jerky movements, and it was a case that we were doing actually seated at the end of the table. And as that jerky motion happened, a scalpel flew up off the instrument stand, and I could watch it in slow motion. And it went right into my thigh. This
Oh,
sharp scalpel literally, I mean, felt like it bounced off the bone of my thigh. I jumped back from the table. I went outside the broke scrub, went outside the room, put my knee up in the scrub sink and washing this out, against contamination and everything. It wouldn't quit bleeding, and I finally, actually, one of the scrub personnel brought me a suture and I sewed up my own leg, 2 stitches to get it to stop bleeding. No local anesthetic. I didn't need any. I was just all fired up because the thing was, I was afraid that because of the nature of that case, I had just been exposed to hepatitis C, to HIV, all these potentially lethal diseases. And I was like, I'm 1 week in and my career is ruined. And I had to go into, you get into this testing protocol once you have a blood exposure like that and everything. But the truth of it was that, first the patient was tested and they didn't harbor any of those diseases. And then, I ultimately went throughout the testing and, and I'm here today, 30 plus years after the fact to talk about it. And I really just felt like, that was a true example of grace that, but for the grace of, I guess, God in that case, I could have been killed from
Yeah.
somebody's simple mistake, and as I've thought about it, there are so many things throughout my whole life that have been grace filled. And that's just one of them, a fairly, dramatic example, but I
Oh,
think
that's dramatic.
yeah. The key is recognizing it when it happens, and it happens a lot.
Yeah. Well, no, that's very powerful. Grace is a gift given to us with no strings attached. But I know, Dr. Philip Brown, you have paid it back in many, many, many times over, and you're continuing to do it in your newest project. Do You Speak Patient? So thank you. So how can people find you and the book? Sure.
Yeah, the easiest way, the book's on Amazon. Do You Speak Patient? You can get it in Kindle format, hardback or paperback. You can find me at docphilipbrown.com and get in contact with me electronically there. Or you can find me on LinkedIn at Dr. Philip Brown, or on the podcast, on the Unlikely Intersections podcast, a YouTube channel, Unlikely Intersections. Any of those places.
Many ways to connect with you, my friend. So with that, we will go out and I say thank you.
Thank you, John. I really appreciate the opportunity to talk with your guest today.